Good morning, friends. Let's get going straight away to our advanced course on PVR, how to counter the scourge of PVR. Uh, uh, the faculty who are going to speak to us, they're really a stars faculty and who need no introduction. Dr. Lingam Gopal, he's a teacher to most of us, a mentor to most of us, and God to me. The others are extremely good friends and also my teachers. I'd request the audience that if you have any questions, please pass them on in writing if possible, so we can address them at the end. Some of the speakers might need to leave a little bit earlier, so they could perhaps be addressed if you've already written the questions and given to me. Since this is an advanced course, we are not going to go into all the basics of PVR like the classification, etc. PVR, we must remember, it starts when the retina breaks. There's a breakdown of the blood retinal barrier. The photoreceptors are ischemic. RPE cells are liberated under the retina and into the vitreous and over the retina. There is inflammation, multiple cells migrate over there, cells undergo transformation. Eventually, there's scar tissue formation, and slide is not advancing. Hello? Yep. No, you've gone. And laying down of scar tissue on the surface of the retina, under the retina, in the vitreous, particularly the vitreous base over the ciliary body. And this leads to complex configuration of retinal detachment. So a key step here is what is called EMT, or epithelial mesenchymal transition. So when the RPE cells are released, when the retina breaks open and the RPE cells move into the subretinal space, then through the break onto the vitreous and over the retinal surface. But as they move, they lose their polarity as seen over here. There are changes within the cell also occurring, and it's more like a rudderless ship, and it just settles where it goes and bangs. Now, if a critical number of these cells have settled at a given place or over various surfaces, and they undergo, because of all the chemicals involved, they undergo transformation into myofibroblasts. So they lay down scar tissue and they contract. So this results in a pull on the retina, resulting in reopening of breaks, or in, no, again the slide is not moving, sir. Reopening of breaks or creation of new breaks, etc. Within the retina, glial cells and Muller cells, they play an important role because photoreceptors are lost. Their connecting bipolar cells also undergo degeneration. So Muller cells, they expand to try to fill up the gap, but they also get transformed. And when a lot of them get transformed, it leads to intraretinal scarring, or what is typically called retinal shortening. A lot of chemicals are involved in all this. EMT actually is a physiological process. It's for wound healing. But when the wound healing goes haywire, like in a keloid, that's when PVR occurs. And to these various molecules involved, various attempts are being made about how to stop this process from going overboard, and thereby how to prevent PVR occurring. Risk factors, all of us know. Some of the new ones would be, not new, but relatively unknown ones would be cigarette smoking. One more reason why people need to give up tobacco and smoking. Gas injection while doing scleral buckling also tends to trigger PVR. because of fibrin secretion and inflammation, and genetic and immunological factors are involved as well, apart from so many of the known factors. So the maxims that I follow is remove as much of the vitreous as possible. Particularly, one needs to be meticulous in base dissection, relieve all the traction on the retina and ciliary body, leave a clean macula, wide ILM peeling at the posterior pole and resurgeries. PFCL, endodiathermy, and laser should be used judiciously. Keep a wide armamentarium of microinstruments ready to deploy, and create retinotomies and retinectomies only if necessary. But when one decides to do a retinectomy, be very generous about the extent. Do not hesitate to buckle. Buckle is not outdated or old-moded, old-fashioned. Use appropriate tamponade for sufficient periods of time, minimize damage to the anterior segment, and good control of postoperative inflammation. Now I invite our first star speaker, Dr. Ramandeep Singh. He's a professor at PGI Chandigarh, extremely good in his work and very, very knowledgeable. He is my teacher for OCT. As I said, all the, apart from Dr. LG, who's my god of vitreoretinal surgery, all the other friends have been teachers in some way or the other. He'll speak to us about principles of PVR management.
Thank you, Dr. Kamdar, for this invite and wonderful, thought to speak on the PVR. So I'll not wasting much time. I'll just, I'm given the task of working on the principles of that. This is a happy VR surgeon in the evening, because he doesn't care retina off or on, but I'm always on. But back of the mind, Chief, you used it in the morning. I got the catch line from the guy who gave me this line in the morning. I'm thankful to God we met in the morning. So I'm always on. So why I'm always on, but at the back of the mind, we remember that I operated this RD, and whether it's going to fail or not is not in my hand actually. So I am not really on there. So the principle is, we all know the principle of RD, find the brake, seal the brake, and support the brake. There is no definite principle for management of PVR. We should all know that, all right? So what I will try to, like he said, we have a PVR. Any tissue which is vascular undergoes a surgery or insert, be in the eye, be in the throat, be in the ear, be in the shoulder. It will form a scar which is not, you can't do anything about it, because we are trying to find out ways to tackle it mechanically, but people are working now pharmacologically. I think Dr. LG will address upon it. I'll not touch it. I'm touching only the mechanical part, where the struggle that is going to come. So the pre-operatively, the treat early. Don't make your RD surgeries wait. Like, these guys, you can't shoo them away. Treat them, operate them as early as possible. Don't think that I'll operate next day or 3 days, because, if you have RD with CD or young patients, we all know that you have to treat them early, but treat them rarely early, these patients, because that concept that once you develop a PVR, let it mature, no, that idea is gone now, because there is a PVR, something called intraretinal PVR also. What we used to call it, our professor used to call it retinal shortening will be there. Put a buckle there. That shortening is because of the intraretinal PVR. So don't wait for the PVR membranes to mature so that you can pick them up as a one toto. This doesn't happen nowadays. So treat them early. So again, the post-operatively is in our hand. So don't let them have an inflammation. Don't let them linger on. If they have inflammation, give them oral steroid for short course, not for 3 months or 1 month. And don't let the inflammation set in, because it will be a cycle which is not be good to you. Then intraoperatively, where I'll be talking about all my skills there. The basic principle of any RD surgery, be it a first surgery or a last surgery, time spent that day is a time saved. That you have to remember. The youngster has to remember. Any RD surgery is not a 1-hour job. Forget about it. It's a surgery which you have to take under GA. Take it. Don't worry, because I don't want my patient. I want my patient half dead there, because I don't want to talk to him. I don't want to ask. He moves that. He wants me to finish the surgery early, because I don't want that. But time spent is time saved. These are the eyes where you have to spend your time there. The principle which I follow is find the posterior hyaloid. Like Sir said, look for the PVR remnants. You really have to dig hard, as if you are digging for diamonds or the gold, because you will find the planes of PVR lift it. I mean, whatever you do have to do, you have to do. And you all know which are the maneuvers you don't have to do in the surgery, which may induce more PVR. And those maneuvers are, you know, that you are not supposed to do excessive cryo. Again, the retinectomies, the large retinectomies, that cycle will never end. More retinectomy you do, more EM, more the times you will go inside, and then you have to resort to other things. So when I say find the hyaloids, these are the patients you have to spend time, you know. I'm very fond of these Tenno scrapers. I'm very fond of these, you know, staining with triamcinolone. I'm old school. I spend time on the macula, but this is an eye which has been operated already, and to my, you know, and failed RD. When we are, you know, scraping over it, I couldn't find, you know, the hyaloid there. I tried my vacuum. I tried everything. But when I was doing this, you know, maneuvers with the Tenno scraper, I could find a you know, a small fibril there, and look what happens due to that fibril. You know, I was able to pick the whole hyaloid there. This is what you have to do this, because hyaloid, and then go to the periphery, wherever you have not supported your retina, go to the far vitreous base. That is very important. You know, this is what you have to remember. And then once you have taken care of the hyaloid, before PVR or after PVR, now you know that you have to deal with the pre-retinal, which we always been taught that there is a pre-retinal PVR, there is a subretinal PVR, and you have these instruments which we all say that because of the MIVS we have lost our cat's paw and lost those things. But I think we have gained also so many things. We have now closed chamber. We don't have a risk of a hemorrhagic choroidals. We have a fast closure. We have a, you know, the less inflammation. So we have these new instruments. So use Tenno scraper. Use your, you know, the new instruments. You know, I'm forgetting the name. This used for the ILM peeling, and these can be used. Of course, the stains. You have your triamcinolone. You have your dyes. And now you have the filters there in your imaging instrument. So this is what you have to do. And this is a video now. I'll run my videos there, and it will show you what is happening there. So this was a case of a, you know, PVR. You know, this is what I normally do under high magnification. You know, I first of all I try and remove all the visible membranes there. You know. You can see that I'll have either a end gripping forceps or a max grip. I will not use a ILM forceps for this maneuver. So I will try it gently. I will not try to whip it off, you know, and cause a macular hole there. I try to lift these membrane without staining it initially, because I am able to see them. This is what I have to do it very, very slowly. Some hemorrhages will occur. Don't worry about them. You may have to increase the bottle height, but never cauterize them. Wait. Don't be in a hurry to cauterize them. And the clue of a membrane is a dirty looking macula, or you will see a segment of a vessel which is missing. Suddenly you see a rail going and track is missing. So you have, nothing is missing. You have a, you know, membrane over there. So you have to lift it meticulously. And again, the PFO is there. You can use PFO initially in your career. You must use it, but always remember, with the PFO, there is a tendency that you will leave a ERM or even a hyaloid there. But always remember that with the PFO there in the posterior pole, you can pick up these membranes. Then I'm very fond of this, you know, putting triamcinolone in the eye. I just put it liberally, and then I put my buckle, and then I come back again, because I believe that if I put a triamcinolone there, it leaves there in the eye for some time, it loosens the tissue. This is my belief. I don't have scientific proof of that, but I inject it and then go and tighten my buckle there actually. So this is how I will go posterior to anterior with my Tenno scraper, always posterior to anterior. I will not go the other way because it will cause a break. This is designed especially at 30-degree angle, and this has a diamond there, but since we reuse it lots of times, so we tend to lose that touch there. So always try to find a new diamond scraper there, and then you either you shake the eye to take care of these, the triamcinolone particles. Then you have to do this maneuver again and again till you are satisfied that you are not left the membrane there. This is what is time spending, because again, what I said, the time spent. This is where you have to keep, trying, keep opening up these small, the nodes there, because you know that there is something there which is not allowing the retina to open up, because you don't want to open it with the PFO. You don't want to push it back with the air, because eventually it will go, but it will come back again. So this is where you have to loosen up. Until the time you see a loose, moving retina, you will not give up. All right. So this is what you do in these patients, and ideally there should not be a a triamcinolone particle which should be sticking to the eye. And if it is something is sticking to the eye, that means something is there. And after doing this surgery, I mean, you should have, you can see that this kind of a picture is very important. You will see that you will keep losing the Kanakot particles from the eye. Then you go to the periphery. Remember that in the periphery also there are membranes there. The instrument we use, either you use scraper or you use these forceps again to lift each and every island of a PVR membrane, because there is a potential that they will form again, or if they are present, they will grow like anything. This is where you have to do the struggle. Another video where you see that there's a large break, there's an open funnel. After I have put this, and you will, this is a max grip there, you will find the nodes there, and then scraper will help you to find a node. Once you reach the node, then that help that node with this thing. And then you can see this dirty looking macula now. I know there's a membrane there. You can go and put I've already tried triamcinolone. I said that I'm very fond of triamcinolone. I don't normally stain with ILM there. You can see that there's a membrane over the macula. That is why this dirt is going. So this is nothing but your PVR, which you would have left if you have not gone there near it actually. So sometimes you're lucky, you'll be able to pick up these PVR as a mature membrane, full membrane. This is what we were waiting for, and for the delay the surgery. Sometimes these situations do help, and if you're lucky, you'll be able to pick up in toto this PVR actually. So now there comes the subretinal PVR. Dr. Naresh Babu is sitting there. He will show you excellent videos. I'm really impressed with his videos of subretinal PVR because there are different maneuvers. I just wanted to show you how this PVR looks like. This happens to be a case of RD which had a subretinal PVR. See the webs there. And if you ask any big surgeon, they all have seen this subretinal. What kind of PVR we see in the on the pre-retina, everything is there on the subretinal also. I wish I can go from behind and remove all these things. That is why PVR removal is the most difficult thing. If we can find something, topical drops or pharmacologically, nothing like it, because mechanically I cannot remove these. This is impossible. But I should spend time to my, where I should think that I have done enough, because ultimately they'll all come back. So this is how the PVR, subretinal PVR looks like. And this is the one video which is, we conventionally, the teaching is you go make a retinotomy, and from where you're planning to drain, through that retinotomy only you go and pull these out. Dr. Naresh Babu has excellent videos from he goes from behind, and that whatever works in your hand, you have to take it out. You do not chase all the PVR membranes, remember that. Only the membranes which are not allowing the posterior port to set. If they break there, fine with it. Don't chase them, all right? If they're in the periphery, don't create unnecessary retinotomies to remove them, because your buccal will take care of these things. So this is, you have max forceps, you can use a sandwich technique, you can use other instruments, you can use anything to remove this. You have seen these videos number of times, but you should know that. What about now intraretinal PVR? What is going on there? This is what if you read about you can't do anything about intraretinal PVR. What people have said that, the ILM is doing that intraretinal PVR. I don't believe it, but still I don't propose doing ILM peeling in a fresh case of a RD. And this is just to show that if you have removed a PVR, this was the same case, first case, if you remove a PVR, you will see mostly the PVR, along with the PVR, your ILM has already been peeled. So this is my point, this is my point. You want to remove ILM, remove it if you want to. See this case, you can see the ILM edges there so nicely. So ILM is already peeled in that area where I have removed those membranes with my naked eye using microscope. I did not use any dye there actually. So it is already peeled. But this is how, but still we do it. All right, fine, but time will tell whether we are taking care of intraretinal PVR by removing ILM. It's a difficult surgery, but people use PFCL. Well, that my tip is, don't remove the SRF first do ILM peeling. When the SRF is thick, it is taking care of that movement. If you have a liquid there behind in the subretinal space, the retina will flatter more. SRF is always thick, so if you have to remove it without using PFCL, so remove it initially. Don't remove SRF, and if in case it's a bullous RD, use PFCL. If not a bullous RD, remove without removing the SRF. Thick SRF will take care of that movement of the retina. So why are these maneuvers are being done? Basically, we are avoiding retinectomies. Retinectomy means the vicious cycle of hypotony, diflupred. No solution for hypotony till now. You all know that. Hypotony is incurable right now. Dr. LG and their teams are working on vitreous substitutes. I'm looking forward for those vitreous substitutes which we can fill in the eye for whole life, which will take care of the hypotony. Again, the recurrent ERM formation will occur. So the last slide is, we are waiting for the pharmacological advancement. Till then, you have to do everything to reduce the PVR pre-operatively and post-operatively, and you have to do those surgeries very, very meticulously, taking care of all the instruments, all the machines, all the knowledge you have in your mind. Thank you so much for your patience.
Thank you very much, Dr. Ramandeep Singh ji, for a wonderful talk. Questions we shall address at the end. You can please write and give it to me. Our next speaker is Dr. There's a little change in the order because of overlapping presentations. Dr. Karobi Lairi, who's the Director of Vitreoretinal Surgery at Bombay Hospital, and a very prolific surgeon and who's an expert at ROP surgery. She'll talk to us about nuances of PVR management in the pediatric population. Pediatric age group, the vitreous is more formed, more adherent, and they have all the growth factors, etc., are much stronger in them, and hence the PVR is also of a more malignant variety, if I can call it so. So meticulous management is very essential. Dr. Karobi.
Thank you, Paritosh, for including me in your IC. I am going to talk to you about the nuances of PVR in the pediatric age group. Now, these are the whole gamut of conditions where you can get detachments in children, which can be of the tractional nature or a hemorrhagic RD, or it can be of a heterogeneous variety. And of these, the most important are the traumatic ones and the ROP, and also congenital malformations such as Stickler's syndrome and all the other syndromes which also occur with retinal detachments. So we have to know that pediatric retinal detachments with proliferative vitreoretinopathy is a very complex condition, often presented with chronic macula of detachments, poor visual acuity requiring specialized surgical intervention. And if this is accompanied by nystagmus, strabismus, hypotony, cataract, uveitis, and leukocoria, you can be sure that this is a poor prognosticator and they are indicators of chronicity. Now, pediatric RD is often detected later than the RD in adults. Why is it so? Because children many a times mask their visual defects, and sometimes they don't even come to know if it is unilateral, and these leads to delayed diagnosis. Typically, the visual acuity is poor, and to tell what is the duration of the RD is very difficult. Pediatric RDs can be missed out also on initial examination because either there is poor fundus visualization secondary to non-cooperation, media opacity, or incomplete mydriasis. PVR in pediatric age group, the challenges are due to unique anatomical and physiologic characteristics, and the characteristics are faster progressions, more cellular proliferation and contraction, and therefore it increases rapidly. It's very aggressive and gives rise to aggressive scarring and complex surgical management. Difficulties are that apart from all that we have said, the PVD does not occur. The PVD creation is much more difficult because it is more complex formed vitreous, and the membranes are more difficult to peel. The surgical challenges are because the eyes are small. There is an underdeveloped pars plana in most of the ROP cases. premature cases and also in children. The retina is very fragile, so the complication of iatrogenic breaks is more. Lensectomy complicates these issues because you have issues later of the child going amblyopic, and you require other devices to make the child see. Higher recurrent rates of PVR needs multiple surgeries at time. The retinal stiffness from scarring makes the reattachments very difficult. Problems are of anesthesia because these have to be under GA. Positioning is very difficult because they won't listen to you, and no standardized protocols are there. So just to see that, this is one of the videos which shows that there is no formation of the PVD at all, and you really have to sort of take it off from the surface. And if you get hold of one edge, then you have to slowly peel it off. And the peel becomes very gradual. It's very sticky. It kind of adheres to the surface of the retina. So your progress has to be very slow, and you have to do it very cautiously and patiently. And finally, you've achieved the separation. The next one shows a little more worse case where it has formed a star fold at the optic nerve head. There are membranes which are contracting the retina. This child had a unilateral detachment, didn't even know there was a detachment. He came for a routine evaluation with his parents, and that's how it got detected. And this had to be removed under PFCL. There's a whole chunks of membranes which are there on the surface. The ILM peels, yet there is a kind of a fold at the macula. And after straightening out, doing the endolaser, that is at the conclusion of surgery. A third patient is a patient of trauma. You have to be sure that you have peeled off the entire PVD, all the scarring, and you have to do a patient job even if it takes time. And this is where, after you've cleared the retina, cleared the vitreous hemorrhage, you go ahead and so the key to optimizing outcomes is for an early diagnosis, for tailored surgical techniques, and long-term follow-ups are very important. Now, the pediatric RD has a worse prognosis than an adult. The RD, due to higher incidence of delayed presentation and macular involvements, is the reason for the same. And their more common initial presentation is because they tend to develop these kind of membranes in the subretinal region. So if you have a patient who has got a lower grade of PVR, it is better to do a scleral buckle rather than jump in for a vitrectomy, because if you create the tamponade by a buckle and the drainage, and the retinal pigment epithelial pump is healthier, so it pumps out the subretinal fluid also better, and the visual acuities are definitely much better than what you would get if you had sort of attempted a vitreous surgery. But if the firm adherence of the pediatric cortical vitreous makes the pars plana vitrectomy more challenging in these children, and there's a potential for iatrogenic breaks during the induction of the PVD. And if there is an incomplete PVD removal, then you can land up with a recurrent detachment and multiple surgeries thereafter. And this can be assisted, the PVD induction, by triamcinolone staining and a flexible loop scraping. Segmentation can be an alternative to delamination for preretinal fibrosis tissue removal. Now, another technique is whereby you remove the mid-peripheral vitreous first, so that it separates the vitreous of the periphery and the posterior pole. So then, sort of causing a little traction on the posterior vitreous becomes much easier thereafter. But in unavoidable situations where there is higher grade of PVR, you have to do a vitrectomy if there is also a vitreous hemorrhage, or if there is a cataract or lens subluxation, a giant tear, coloboma, or recurrent RD. So you do the procedure which I just spoke to you about. A lens-sparing vitrectomy is ideal because then the prevention of amblyopia and glaucoma is there, and cases with choroidal detachments or funnel RDs need a limbal approach many a times with lensectomy. So robust post-operative inflammatory response worsens the PVR in the post-operative phase. Poor compliance to medication leads to excess scarring. Long-term visual outcomes are poor. There's a risk of amblyopia, so you have to address that also. And poor central vision is because of macular involvement many a times. So the facts are, when there are single surgeries, the success rate is about 73.3%. The reattachments are better for traumatic and lower for congenital or developmental retinal anomalies. Amongst all forms of primary retinal detachment, the traumatic and the recurrent retinal detachment have a better anatomical success rate than the TRDs. And despite a range of wide surgical approaches, PRD has a low surgical rate of reattachment compared to that of an adult RD. Even successful anatomical reattachments, the eyes are often at a risk for amblyopia. So what are the potential solutions for the future? Early diagnosis and treatment, adjunctive therapies with anti-VEGF, steroids, anti-PVR agents, improved surgical instruments, smaller gauge instruments, better tamponades, and amblyopia management. And co-management with a visual developmental specialist or a pediatric ophthalmologist is essential for maximizing functional outcomes in a pediatric retinal detachment patient. Thank you for your kind hearing.
Thank you, Karobi, for a wonderful presentation. The one tip that she didn't give, and which I have learned from her, apart from a lot of things about ROP, etc., is that she is very compassionate with her patients, and that's what wins over the patient and the patient's cooperation, because small kids, you know how cranky they can be.
Yes, you have to make all kinds of animal sounds with them. Then they listen to you very nicely. Thank you so much.
Thank you, Karobi.
Thank you, Pai.
Thank you. Our next speaker is Dr. Mahesh Shanmugam. I'm sorry, we are changing the order a little bit because he has to present himself elsewhere. And you'll put sir last. Thank you. Dr. Mahesh Shanmugam is the Director of Vitreo Retinal Services with the Shankara Group of eye hospitals. Excellent surgeon and with great experience in dealing with ocular tumors. And he's a good friend. I've learned a lot about ocular tumors from him. As I said, all the star speakers, they are my teachers. So Mahesh is also one of them. So Dr. Mahesh Shanmugam will talk to us about management of PVR following treatment of ocular tumors.
Mike?
Yeah, it's working.
Yeah. Thank you so much, Paritosh, for the kind introduction. But of course, I'm not a teacher. I learn from everyone. And so Paritosh wanted me to speak about management of PVR and ocular tumors. Lights are not moving. Okay. So what is different in PVR and ocular tumors? So retinal detachment is, as far as ocular tumors is concerned, it's usually associated with vascular tumors, particularly retinal hemangioblastoma and retinoblastoma. So in addition to managing the RD and PVR in these patients with ocular tumors and retinal detachment, what we need to look at is the management of the tumors itself. So when we go inside and do a surgery, we have to take care of the tumors. In addition, we have to take precautions to avoid extraocular spread of the tumor and also minimize risk of disastrous hemorrhage, because some of these hemangioblastomas can bleed disastrously. So vitreous in tumor-related retinal detachment is different, and it's actually a sick vitreous because of breakdown of the blood retinal barrier. And there are anomalous adhesions to the tumor, to the areas of treatment-related scar, such as the cryotherapy. And it's not just PVR, it's usually a fibrovascular proliferation in these patients, as you will be seeing. So let's look at some clinical examples. This is a retinal angioma recommended the retinal detachment with fibrovascular proliferation. So this patient has a total recommended retinal detachment, and you can see the vitreous itself is kind of sick with infiltration of the blood and inflammatory mediators. So there's not much PVR in the posterior pole, but you can see the extensive exudation because of the peripheral angioma. And the vitreous can be peeled off reasonably to the periphery, but then the area where the tumor was, that's the area of the tumor what we see here. There's a big mass of fibrovascular proliferation along with the tumor. So here we try to dissect as much as possible anteriorly. Here what we see is the feeder vessel treatment. The feeder vessels supplying the angioma are being treated. The retina is reattached, silicon oil is placed, but the area of the tumor and the fibrovascular tissue, here we are supporting with a broad buckle. So here we see a 42 band, a 4 mm band, and the tumor area and where the break was with the fibrovascular tissue, we are able to support the band and close the break. The break was close to the tumor. So in this patient, this sufficed. So, but in the next patient, same with the hemangioblastoma and retinal detachment. Here once again we placed the buckle in the area of the tumor and went ahead, did a vitrectomy. Again, there's no PVR as such posteriorly, but close to the tumor is where you see the proliferation. This patient had a macular hole as well. So we drained the fluid from the macular hole, reattached the retina. That's where the tumor was. So we peeled the vitreous as much possible close to the tumor and wanted to take care of the macular hole. So did an inverse flap of the internal limiting membrane to close the macular hole. So here we try to dissect. As you can see, this is just not a tumor, it's a fibrovascular proliferation which is pulling up the retina and causing the break to remain open. So here we had to resect the tumor and the fibrovascular proliferation. So this is a phakic patient. Being a young patient, we are able to remove the fibrous tissue. I don't know what happened now, why it stopped. This is a phakic patient. We are removing this mass of fibrovascular tissue and the tumor in the periphery. This is one of the rare situations where we remove the tumor as well as the fibrovascular tissue around it and creating a retinectomy. And the edge of the retinectomy fell on the buckle which we had already placed. The buckle was placed to support the tumor, but here we had to resort to a retinectomy. So in retinal detachment with PVR and angiomatosis retinae, preferable to avoid retinectomy and excision of the tumor because it increases the risk of anterior hyaloid proliferation and hypotony. In the rare situation, this is when we resect. Usually I support the tumor and the associated proliferation with a broad buckle, and tumors which are very large to be treated with cryo or laser, do a brachytherapy, regress the tumor, and then subsequently take care of the retinal detachment. And prognosis is generally poor in VHL disease. As you can see in this patient, this is a one-eyed patient, been keeping it going for the last 10-15 years, but then subsequently I had done a limited vitrectomy for a vitreomacular retraction, but then about 5 years later she lands up like this with a total retinal detachment, and the vitreous base is completely proliferated with fibrovascular tissue and totally adherent, and she had numerous tumors, countless number of hemangioblastomas in the periphery. So ultimately we had to resort to a retinectomy. You can see the vitreous anterior to it is completely adherent, proliferated, the mass of fibrovascular tissue, tumor, and neovascular tissue. So a 360-degree retinectomy is being done to attach the posterior pole. You can see this mass. So there's a mass of the tumor plus fibrovascular tissue and a neovascular proliferation. And it was extremely thick that it couldn't even be cut with the cutter. So we had to resort to a bimanual dissection, and that's the mass what you can see. This had to be cut and then removed, so that like you can release the traction on the posterior retina and reattach the posterior retina so that she is able to see. Now it's about like 4 years since this surgery. She does have hypotony with oil inside the eye, but she is ambulant, around 660, 636 vision. It's a desperate attempt because VHL RDs are particularly bad, so they can keep proliferating. So that's the perfluorocarbon used to reattach the retina after 360-degree retinectomy and removal of the scar tissue. So retinal detachment can happen in retinoblastoma as well. So it can be secondary to a cryo-related break because we do excessive cryo in retinoblastoma to treat the tumor as such. And post-chemotherapy also can be a retinal break because of it can happen. It has been known to happen after intravenous chemotherapy as well as intraarterial chemotherapy. What happens is when the tumor shrinks abruptly, the tumor is within the retina, it causes retinal breaks. So that can result in a retinal detachment. So endophytic tumor and extensive vitreous seeds and no subretinal fluid are the risk factors that a particular child with the retinoblastoma may develop a retinal detachment. So preferable to do a buckle if it is possible in a patient with a retinal detachment, that we don't go inside and do a non-drainage buckle. But then we usually wait, but if it is not possible, the earlier teaching used to be we usually wait for about 6 to 18 months for the tumor to regress and do a vitreous for cytology and adjunct melphalan and topotecan infusion and go ahead with surgery. But currently we don't usually wait. So this is one such patient, one-eyed patient, the other eye had been enucleated, and this is how it was. So total retinal detachment with PVR and a tumor posterior pole. The greenish hue you see is the intravitreal, the topotecan which is added to the infusion fluid. So that's the area of the cryo which had been done, and that's proliferated, giving rise to a PVR. So a retinectomy had to be done in that area, and all the preretinal membranes had to be removed. And the tumor posterior pole, we just left it like that. So this is subconjunctive distilled water. Distilled water is known to kill the tumor cells. So we do cryotherapy to the sclerotomies, as well as give subconjunctive distilled water to decrease to kill the cells which may have migrated out of the eye.
Contains chemotherapeutic agents. So the local precautions, we have to take steps to minimize extracellular.
So in vitrectomy, active retinoblastoma, the precautions are to avoid scleral buckling in active retinoblastoma, because you may be spilling the cells into the orbit. And steps to minimize extraocular spillage of cells are we used a valve cannula, and every time the instrument comes out of the way, switch off the infusion so that there is no efflux of fluid from the vitreous cavity. And as I mentioned, we usually add chemotherapeutic agents in the infusion fluid and at the end of surgery. It's melphalan or topotecan. And the vitrectomy, whatever specimen is taken from the eye is sent for cytology to see if the tumor cells are active. And once we close the sclerotomies with a suture, we cryo the sclerotomies. And as I showed, a subconjunctive melphalan or distilled water is used to kill cells which may have spilled out of the eye. And usually a vitrectomy is done under cover of systemic chemotherapy or external beam radiation, and repeated intravitreal chemotherapy if required may be done. To summarize, PVR and tumor-associated RD is not simple PVR. It's associated with fibrovascular proliferation, and we have to appropriately manage the tumor in addition to managing retinal detachment and the PVR, and meticulous precautions should be taken to prevent extraocular spread in malignant tumors. Thank you so much for your kind attention.
Thank you very much, Mahesh, for a wonderful talk. It was very enlightening. Thank you. Our next speaker is Dr. Naresh Babu. So you'd like to go in next? Okay. Our next speaker is Dr. Lingam Gopal, sir, and he is going to talk to us about measures to prevent PVR. Sorry, sir. Anyway, sir. So, while your talk gets set up, may I request Dr. Mahesh to please present a memento to Dr. Ramandeep Singh.
At the outset, I would like to thank Dr. Paritosh for an opportunity to be in this interesting instruction course. There will be, unfortunately, some amount of overlap between the talks because the topic is such. So first, about origin of PVR, you were already introduced to in the introductory comments of Dr. Paritosh. But I thought we'll make it a little more elaborate in the sense that the contribution for the origin of PVR is not just the retinal pigment epithelial cells, but even the process of vitreoschisis, or the so-called anomalous vitreous detachment, leaves behind vitreocortical remnants, which can also result in PVR process. The RP cells and the epithelial mesenchymal transition, and also the spindle cell proliferation, leading to collagen formation, has already been discussed. And BRB is a very important part of the overall pathogenesis, wherein you get factors which are blood-derived, not retina-derived. They are cytokines and inflammatory cells. How do I move these slides?
Slide name.
Yeah, okay. So then I'll just say next slide as well. All right, okay. So can you go back one slide, please?
No, sir, I think you can move it back.
Yeah. So there are also other cells which are not as evident in the literature and in our knowledge. They are the hyelocytes and Mueller cells. Hyelocytes, the concept is that there are cells in the anterior hyaloid which can actually recruit retinal pigment epithelial cells. In fact, their role has been not known very well until recently, and they have been shown to be important not only in the development of retina itself embryologically, but also in the development of PVR. So they recruit RPE cells, they also recruit glial cells and monocytes, and actually can be responsible for PVR. And they can actually transdifferentiate into the alpha smooth muscle actin positive cells, which contract and cause the fibrosis. Mueller cells can also be insulted by the ischemia that is occurring because of the retinal detachment. And this prolonged ischemia leads to Mueller cell hyperplasia and gliosis. That's what leads to the intraretinal gliosis, which is characteristic of a chronic PVR process. The proliferation of fibrosis, we all know where the fibrosis can occur. It can occur in front, it can be behind, as well as within the retinal tissue itself. I won't go into the details of that. Can I have the next slide, please? All right, now what are the risk factors? These are all what we need to know so that we can know, can we modulate the risk factors? Before the detachment itself has occurred, we know there are certain factors which make the eye predisposed for PVR if and when it develops detachment of retina. That is an injured eye, where especially a penetrating injury leads to a lot more disruption of the layers of the eye, including the choroid and the uveal tissue, that makes it more prone for retinal detachment, even before the detachment has occurred for PVR. Previous inflammation, if you operate on a uveitic eye, which has developed retinal detachment, the risk of PVR is increased. Aphakic eye in general is said to increase the risk of PVR, although exact reason is not clear. Systemic conditions have been already alluded to by Dr. Karobi Lagri in her presentation, and smokers have also been alluded to by Dr. Paritosh Kamtar. Exactly the relationship between smoking and this is not known, and I'm not sure whether stopping smoking a day before our retinal detachment has occurred can really influence the PVR. Next slide, please. But we all know more about the factors which come along with detachment of retina. These are large breaks, giant retinal tear especially. So larger the break, more the access of the RPE cells to the vitreous cavity. So more the cells liberated, they can easily cross the threshold required for PVR process. Presence of vitreous hemorrhage with retinal detachment again increases the risk because more blood in the vitreous cavity, more access of the blood-related factors into the vitreous cavity, the cytokines. Presence of choroidal detachment is an indicator of the inflammation in the eye as triggered by the retinal detachment, and that can again be an important factor. Also has shown are more than 2 quadrants of detachment of retina, and presence obviously of a detachment for a long enough time can lead to more scarring process. Next slide, please. But during surgery, there are also factors like excessive cryopexy. In general, we shifted away from cryo to laser, especially when you're doing vitreoretinal surgery. But if you're doing a scleral buckle and you're freezing the entire retina all over the place because there are multiple lattice patches, you increase the risk of PVR. And especially somebody who is a novice surgeon will tend to freeze the eye much more than an experienced surgeon. So it always is important to titrate how much you can freeze without increasing the risk of PVR. Subretinal hemorrhage, when it occurs as a complication of subretinal fluid drainage or a retinal incarceration, can also increase the risk of PVR. Next slide, please. Post-surgery, the role of inflammation has been already alluded to by Dr. Ramandeep. Significant and prolonged inflammation can cause risk of PVR. Post-operative choroidal detachment, even if it has not been there pre-op, can also increase the risk of PVR. But again, I think the one factor which you and I, all of us, can influence is an unsuccessful surgery. A primary surgery which is a failure not because of PVR but due to other reasons could be an important reason for risk of PVR, and that could be really influenced by all of us. Next slide, please. So what are the factors that could modulate? One, surgery as soon as possible. Again, this was stressed by Dr. Ramandeep, that even a 1 to 2 days of delay in eyes with giant tear, large tears, and high myopia can lead to significant inflammation, cause choroidal detachment, and you are forced to postpone the surgery all because you postponed it by 1 day. Now you want to treat the choroidal detachment and then operate. So you increase the risk of PVR. So if you find a GRT, please take it as an emergency, even if it is a Saturday night or a Sunday morning. But if delay is unavoidable due to other reasons, systemic factors, for example, patient is not fit for surgery, then at least start them on topical steroids and atropine before you contemplate surgery. Very often this is missed and the patient comes back to you with untreated with steroids, at least by topical medication. Next slide, please. Next slide. Yeah. Now, when eyes with retinal detachment coming with the choroidal detachment, we know are important risk factor for PVR. There is a role of preoperative steroids, and this has been stressed by multiple studies, even randomized controlled trials. Using oral steroids, Dr. Sharma et al. Have shown that after one surgery with preoperative steroids, the success rate is 81.8% versus 66.7% if we did not give steroids pre-op. With intravitreal steroids, people have shown in this study by Juan et al. Of 13 eyes that the choroidal detachment disappeared in about 10 days after giving intravitreal triamcinolone, and there's 100% surgical success. By suprachoroidal steroid also similarly, success rate has been improved, but not as good as intravitreal steroids. You see the choroidals have disappeared only in 7 out of 10 cases, and there's a 90% surgical success. So intravitreal steroid should not be a problem, except that if you're concerned that in the presence of a choroidal detachment, your needle may not go in, you can still stick it in hard enough for it to be visible in the vitreous cavity if you're going to the ciliary body, which is not detached as much as the choroid. So I'm sure you'll be able to find the needle in the vitreous cavity and inject it. And if in the worst case, you inject into the supraciliary space, which is probably not as good, but still good enough. Next slide, please. What about steroids as a prophylaxis against PVR, not as a treatment for choroidal detachment? In a meta-analysis, studies have shown that including oral intravitreal triamcinolone and intravitreal Ozurdex, there has not been much of a difference between with and without treatment. That is, there is no PVR pre-op, but you're trying to reduce the risk of PVR. It has not been shown to be of much prophylactic value. So, but in PVR, which is grade A and B, which is less easy to define, because what is B? At the most, vitreous haze from RPE cells in the vitreous cavity, but no full thickness folds. That's probably there in a majority of vitreous surgeries you do for retinal detachment. So in those cases, it has been shown that oral steroids or preoperative steroids could be beneficial in reducing the postoperative risk of PVR. Now, if you include all the cases, there is no benefit. Next slide, please. But anti-proliferative agents is something that we try to concentrate upon now. The previous studies have shown that 5-fluorouracil with low molecular weight heparin infusion has been tried in 2 different studies. In one, it showed some reduction in PVR. In the other, it showed no advantage whatsoever. Daunorubicin has been tried in the past with mixed results, but none of them reached the primary objective, which is reducing the number of resurgeries. Colchicine and retinoids have been not found to be useful, and anti-growth factor, that is anti-VEGFs, have been tried with no response. Next slide, please. So we concentrate on intravitreal methotrexate, which has shown some promise. Dr. Narendra Babu is going to probably share some of his studies. But there's one study of a review article by McAllister et al., which has shown that the intravitreal methotrexate has inhibitory effect on RPE cell epithelial mesodermal transition. It neutralizes the glial elements and decreases the cells with the contractile properties. Side effects are very few, but the half-life is very short. In rabbit eyes, it has been shown to be only 7 hours. And we know that the PVR window is roughly about a month to 3 months post occurrence of retinal detachment. So you need to cover the eye for this month period to be able to have the success rate of reduction of PVR process. 100 to 400 micrograms is what is the dosage required. Is my time up already? I'm sorry. Okay. But what I want to stress is that it's injected into silicon oil filled eye. The frequency injection of on the table is 1, and weekly every 2 months for 2 months, and again at the end of the 3rd month, total of 10 in one study. And that has shown significant reduction of risk of PVR. But an RCT with a single intraoperative injection had shown no efficacy at all. The alternative is to use intravitreal infusion during vitrectomy. Next slide, please. And then that probably reduces the risk. The other maneuvers are that a vitrectomy is preferred when there is multiple tears or a RD with choroidal detachment rather than a buccal, even if you have reduced the choroidal detachment by using steroids. That removes the vitreous gel with all the blood-related factors and hence reduce the risk of PVR. Avoiding cryopexy, we already referred to. Fresh RDs should not be allowed to go into PVR, operate as early as possible. And during vitrectomy, very often what you miss is a layer of RPE cells which are stuck in the inferior retina. You try to mobilize them using a flute needle and try to scrape them, even if you want to use a scraper, Tano scraper, and remove those cells. They are not still PVR, no fibrosis, but leaving them behind can lead to PVR subsequently. So remove the cells which are settled inferiorly. Studies have shown that gravity does help in RP cells settling at 6 o'clock meridian. Study by Bert Glaser has shown in rabbits which were actually put on right side or left side or upside down, that depending upon the gravity, the RP cells tend to settle down. So oil versus gas, oil tends to limit the PVR to the inferior fundus, and in the presence of oil, the methotrexate actually may be even more beneficial because it tends to collect in the fluid filled space, and PVR is already also in the fluid filled space. Next slide, please. So in conclusion, PVR is an obviously complex disorder with multiple trigger factors. There may not be one final common pathway that you could actually target using maybe one of these antibodies. You may not be able to find it because the pathway may be different in different eyes. The prevention, mostly by common sense measures can succeed, but they cannot ensure success. Prevention by intravitreal methotrexate appears promising. So even if you don't want to use it for routine cases, use it in high-risk cases or with recurrent PVRs. Intravitreal infusion coupled with postoperative injection may reduce the number of postoperative injections needed. So during surgery, you infuse with methotrexate, and maybe you can reduce the number of injections, but this is still not finalized as to how many injections are required. Reducing the risk of recurrence at the primary surgery, not due to PVR but other reasons, could go a long way in reducing the risk of PVR. Thank you very much for your attention.
Thank you, sir, for a wonderful keynote address on measures to prevent PVR. May I request Dr. Vatsal Parekh to please present the memento to sir. Our next speaker is Dr. Naresh Babu. He's a director of Vitreo Retinal Services of the Arvind Eye Group at Madurai. And he's going to talk to us about management of PVR following trauma, basically traumatic PVR management.
It's on. Okay, check. Okay. Thank you very much, sir. Thank you for making me a part of this IC.
Thank you.
And I am very happy to see a full hall, actually, which is a very rare sight nowadays. So, in this, we'll be basically discussing a few of the tips what we do in case of traumatic PVR. But there will be certain repetitions. Please forgive me, and those repetitions are nice to remember. Okay. So, in case of trauma, so PVR is very high actually. It is as high as 45 to 85%. So the importance of this is like in case of traumatic RDR, vitreous hemorrhage or whatever, where we go for surgery. The important thing we have to tell the patient is no surgery, no patient is going to be cured with a single surgery. So usually in all the trauma cases, we counsel in group and we tell that the patient may even take 10 surgeries also. It is very hard for the patient to and the attenders to digest, but we have to do that. Okay, so the onset also varies. It's not immediately we'll come across PVR in case of trauma. So depending upon whether it's a perforating injury or a rupture or a foreign body, it ranges from a minimum of 1 month to a maximum of 6 months for the proliferation to happen in these cases. But when they proliferate, it is very severe. And these are the factors, and some, as I told, some will be repetition. Usually in any case of PVR, not necessarily in trauma, wait for the membranes to mature, because if you are going to operate on a immature membrane, it's very difficult to remove. The membranes are very slimy. So we always wait for 8 to 12 weeks. Even if the macula is off in case of trauma, no issues. Once the macula is off for a longer time, it's fine. It doesn't make much difference. Wait and then operate. So the goals has been discussed extensively. And the pre-op evaluation is important. Like in case of intraocular foreign body, mostly the patient will come with only the ocular trauma. But in case of a road traffic accident, there will be other collateral damages also to the rest of the organs of the body. So we have to take into consideration the general condition, and all our trauma cases we operate under GA because we cannot tell how much time we'll be taking, And of course, if the patient is having a single eye, or if both eyes lost, there is no way we have to operate in these cases. And the most important is in case of trauma, no PL is not a contraindication, because a lot of people with no PL will improve, and this has been discussed following surgery. So for membrane dissection, which is the important part, we have to go with the right instruments. Prepared for the instruments which you have. And there are many ways of removing the membranes, which has been already discussed. Subretinal membrane and the napkin ring, usually I go subretinally, that is through the sclera, 10 millimeters posterior, but in this case, that video is not there, because in case of trauma, I usually don't prefer that. The reason is in case of trauma, the alteration in the anatomy of the eyeball makes us difficult to go subretinally, so we go for the conventional technique of making retinotomy. The importance of this is using the right instrument, go for the max grip, because the instruments sometimes may not completely pick. And we need to do multiple retinotomies also in these cases. And don't chase all the membranes, even if they are snipped, it is fine. Retinectomy is very important. These are the indications where we do the retinectomy. The most important is the extent of the retinectomy. When we are doing retinectomy, at least 180 degree has to be done. And prior to that, we have to do a diathermy so that there is not much of bleeding. And as a rule, for myself, I don't do retinectomy in the first surgery. Because when we do retinectomy in the first surgery, and if you're not peeling the membranes, the proliferation is so severe that it leads to something called severe intraretinal proliferation. So we reserve that for the resurgeries. So this is one of the case with PVR. So you can see the inferior retina is detached. So by injecting the PFCL, we can make the peripheral retina pullous, and using a diathermy makes the thing avascular. So make a nice diathermy for 180 degrees. Then we can use the cutter to cut. And there are various modalities, types of this thing, cutting. Like usually we go for a linear proportional cutting, but I always use proportional vitrectomy, where we have a separate control for the vacuum and the cutting. So you don't need to switch off the cutter. So nice, we can do a nice retinectomy. And I am very liberal in using the dye so that we can see the membranes, and after that it has to be treated like a giant retinal tear. So we'll just, this is very important because we use PFCL very extensively, and so Gopal sir was telling about putting the what you call band or the suprachoroidal steroid. But in our cases, we found that PFCL as a short-term tamponade, we keep it for 10 days, both as in this case as well as in cases with what you call choroidal detachment. We found this to be very useful, because in case of choroidal detachment itself is what you call promoting factor for PVR change. But if you retain the PFCL, how much ever choroidal detachment it may be, we cannot see even a single mount on day one. By 24 hours, the complete absorption of the choroidal detachment happens, and thereby actually the proliferation is much lesser when we are using a staged approach in case of RD with CD. So we'll go for some of the surgery. This is a bilateral blast injury. One eye is thicycle, the other eye had a K-Pro, and then the patient developed dense membrane. So we have done a membranectomy behind the K-Pro. The problem with these cases is the anatomy is altered. We don't know where to enter. Sometimes we might enter directly. But fortunately, I had a retinal detachment, not much of proliferative changes, only the pre-retinal membranes. And they were all mature and easily identifiable. And as I said, in most of these cases, we go for a stage surgery. Once all the membranes are done, we peel the ILM also. And as was shown by Dr. Ramandeep, you can find the thin sheet of vitreous also. So once it's all done, we retain the PFCL for a week or 10 days. And usually I don't do the laser in the first stage, because after 10 days, usually the retina gets very well attached and the laser uptake is very good. And in most of these cases, we peel the ILM by ensuring, by doing this, we ensure two things. We remove the vitreous, as well as in most of the cases, the proliferation, epiretinal proliferation after the surgery is avoided. So once if you inject, this is the end of the first stage, and then we go for the second stage where we replace that with oil. And this is after 2 months. The BCVA is 5/60, and that is fairly good enough for the patient. So this is another case with, again, a history of trauma with a corneal tear. The problem is there is incarceration in the periphery and a lot of PVR membranes. So usually we do a nice retinectomy at the site of incarceration. Otherwise, how much ever surgery we do, usually it goes for the resurgeries. It's not very clear. So this is after 3 months, the patient has 6/36 vision. And this is another case with closed globe injury with the vitreous hemorrhage. Blood is another important thing which leads to proliferation of membranes. So this case actually, again, most of these cases are single-eyed. You can see a completely crumpled retina. The important thing I would like to emphasize is when we are doing all these complicated cases, 2 things we have to do. Better post it when you are on a leisure day, number 1, and number 2, switch off your, the clock, or turn the clock in the OT room. Don't bother about the timings. And as I said, most of these surgeries are done under GA because we don't want the patient to shout after some time. Okay, so as was told earlier, TANOS is a wonderful instrument. So that helps in basically identifying the membranes also. So we have to dissect all the membranes and we retain the PFCL. And this case had some 1/60 or 2/60. And this is another case of a trauma. As I said, we have to switch off. This is a condition actually. The patient came much later with a complicated cataract, which was done. So extensive membranes. Usually, if the patient's other eye is good, we don't bother to touch these eyes because 1/60 or 3/60 may not satisfy the patient, and our time is also extensive. But if the patient doesn't have, we have to operate. As I said, don't bother up to the time. Take your own time, be patient. So I was fortunate enough to get the plane of the membrane in these cases. Once I could open, then we injected the PFCL. So it's like Kajal's advertisement, soupy noodles, Kao, Pio, like that. You just inject, then peel, then inject, then peel, so that the membranes also gives way. So we kept on peeling, and this is at the end of the surgery. Yeah. So after the second stage, we removed the oil, and it is hard to believe that this was the case actually. So it took a longer time, but it was sometimes very gratifying. So this is the same patient after 2 months with a 2/60 vision. And this is the most important, I'll skip this for want of time. This also I'll skip for want of time. I'll just go for the last case. So this is another case, 46-year-old gentleman. When we refer the cases to our orbit colleague, I hope nobody is there, they usually go for enucleation in these cases. But now it is easy for us to manage sympathetic ophthalmia, so we usually resist going for this thing. This is a case with a flat tire sign, you can see in the CT also. We said, okay, we'll repair. So I don't have the, the video of the first surgery. We have done the AC reformation, scleral suturing was done. And slowly the eyeball improved. And this was after 14 or 15 days. Then we went, this was the status. So the patient was aphakic with a sutured scleral wound as well as the corneal tear. When we went inside, it was a bit bad actually, but still, inside it's not there, okay. Now we have retained the PFCL as I told for 14 days. 10 days, and then we reoperated. And this was the final outcome of this patient. So the patient's vision was again 6/60. We don't expect much. So methotrexate in PVR is very, very useful, and we have our own in-house publication, but it's a very small number. But we found that injecting methotrexate is very useful in these cases. We go for at least a 4 injection weekly interval, 400 microgram. And usually the oil is removed at the end of 3rd month. And one additional thing is what we have found this to be useful is, which is under public, a review now, is in subsilicon oil hemorrhages in case of diabetics. We found this methotrexate, literally enhancing the absorption of the hemorrhage. So we don't have any AC, shallowing or any raised IOP because of subsilicon oil hemorrhage because of this drug. Actually, I'll not say it's a wonderful drug, but definitely it makes a lot of sense. So we had only 20 and 23 cases overall. So we use 400 microgram and weekly interval, as was discussed by Gopal sir. It's a very safe drug because this was used as a first line in case of all intraocular lymphomas, and its safety has been proven already. So we can use it, no issues. And we found that the redetachment is much lesser in the injection group compared to the control group. So in summary, actually traumatic PVR is almost 45 to 85% of the cases, quite advanced, and it is sometimes annoying actually when we go inside. Second thing is no PL is not a contraindication in treating any traumatic cases. So the PVR is a major cause for the failure in this case. So we have to go for a complete dissection of the membrane as well as relaxing retinectomy whenever needed, but not in the first surgery ideally. A short-term tamponade of PFCL really helps. And finally, methotrexate in a dose of 400 and a repeated injection really helps us to get fairly a good outcome in these cases. Thank you very much.
Thank you very much, Dr. Naresh Babu, for a wonderful presentation. I request Professor Dr. Bhatti to present the memento to him. Sir, Dr. Bhatti. Please stay around if there are questions about it. Thank you. Our next speaker is Dr. Pramod Bhende. He's the director of Vitreo Retinal Services at Shankar Nethralaya. Extremely good surgeon, but what one learns from him is that despite prolific surgery, humongous amount of knowledge, his humility and kindness, I think it's something worth emulating. Thank you for being what you are, Pramod.
Thank you. Thank you very much. Thanks for having me.
Speak to us about
it's not showing here.
PVR following diabetic vitrectomies.
What are the names?
Point about smoking till Pramod starts, that smoking causes oxidative stress. It leaks micro quantities of cyanide, which quenches oxygen, and that is how it worsens PVR. Exact mechanisms are not yet elucidated. And as Sir said, non-smoking 1 day or 1 week prior to detachment, whether it's going to help prevent, we do not know. Please. Thank you.
That helps the family also. When if a patient, wife asks for whether husband should stop smoking, and you say yes, he can stop, and then it's okay, you can see the expressions. I think that way it also helps.
Yes.
Okay. So thanks Paritosh once again for having me here. So PVR, post-PDR surgery, I was in dilemma what to do. Managed to pull out few cases. Probably we'll start with a case. Next slide. So basically is a 55-year-old male, uncontrolled diabetes, HbA1c was 11, had a laser PDR, fortunately in a left eye. Right eye had a couple of surgeries, and then he was sent to us with having something picture like this. Left eye was stabilized. The macula is already involved in a scar here, pale disc, and you can't make out here, but what you are looking at here is entire retina was detached here, thin, transparent retina, and ischemic thing. So vision, just hand movements. We decided to leave the eye alone. The reason is, again, the small area was attached superonasally, but being left eye 6'9", N6, we knew no visual potential, no point subjecting, and again, he's one of the adamant, not willing to control his diabetes at all. The another lady, 56-year-old, PDR, also had CRVO, counting finger vision. Seemingly, right eye surgery went uneventful. No complications as such, but it was combination of CRVO, bilateral CRVO, and PDR. So surgery was okay. 2 months, she comes back with this is what picture right there. Basically, ischemic retina, severe proliferation, and whole retina is pulled off. We did attempt the second surgery, but this was second surgery. We could have small island left over at the posterior pole. She has not yet come back for her next checkup, so we don't know whether what she's vision is going to get back. Because again, prognosis was obviously bad, but we did not have choice because other eye is already lost also being a CRVO. This is a third case. 15-year-old male, diabetic since 15 years, PDR, left eye already had 4 surgeries, right eye had 3 surgeries, and right eye had a vitreous hemorrhage, no other choice. And this is the left eye when he reported for another surgery, inferior RD, severe proliferation, whole retina was pulled off here and multiple breaks. This is the picture. And this surgery goes, pale disc, you can see the vessels are closed. Just break here is just temporal to the fovea, not fovea macular hole. And all this proliferation, just it's a highly edited video, 3-hour surgeries in within a minute, so please bear with me. So ideal way is this type, you can start straight with a bimanual surgery here. Inferior retina is pulled off. Again, atropic, you see everywhere is like a sieve-like retina, multiple break. Try to be as gentle as possible. But basically, initially I started with a, not bimanual, but I was using light pipe here as my second instrupate. So what is important, once you get a cleavage plane, what I was doing is holding the membrane in a forceps, not pulling it, but tapping the retina back, and that is what, and that to shaft of the light pipe, and that helps you to push the retina back and separating the membrane, not really pulling the membrane, because knowing retina is like multiple hole sieve-like thing. If you pull the retina here, it just retina comes in a bits and pieces, and that's the way you see here. Slowly it's coming out. Managed to just separate few things. Ultimately start becoming more and more mobile. So it takes time. You have to be, again, I think all of us today we are talking about go slow, take your own time. There's no rush here. Either put as a first case when you have a lot of energy, either put as a last case when you know there is no backlog left. So probably you have enough time for you to do these cases. So eventually this is what we could mobilize entire retina, but also realize there was a shortening of the retina here. PFCL we try to peel other membranes, but eventually what I landed up is, this was a final picture at the end, inferior RR large one, and ultimately, but just satisfaction is we settle down the retina. Let us see how much vision he get back. I do not know yet. And there's one more, both eyes, vitrectomy, silicone oil injection for PDR, and then the reproliferation involving post-repolar. The difference here is when you see PVR membrane in our RD, regular, our conventional thing, and post-PDR, membranes are thicker and they are vascular. These membranes again are having a, because attachment to those left or stop of like a fibrovascular stumps there. So these vessels, again, when you try to peel off, sometimes there's high risk of detaching there and also pulling the retina there and creating more breaks as well. And sometimes, as we will see here, this part is firmly attached here. No way I could get cleavage plane. Here also I was struggling. And this is after oil removal. And like again, trying to peel it off, had a great difficulty in finding a plane, and you don't know where you are going to tear the retina, and you don't know where those attachments are there, where retina and membrane are just one single unit. You don't want to go to the other scars, because if you pull, this is what is left over. Because this edge was stuck, I did not want to pull too much, and last thing I wanted to create a break here, the other thing. This membrane did bleed, took long time for me to stop the bleeding. Eventually he is doing well now, but that was again good eye. And this is the last case, 24-year-old female. This is similar scenario, what you see the last case, but what happened here is this proliferation, and this was a lesson I learned from this case rather than previous case. When I read oil removal, this part I thought is pulling the retina, having a tug on a macular area. I said, let me release this. And during that release, I created tear along this edge. I had to re-inject the oil, settle the retina, re-oil, and then subsequent oil removal. So what happened now? Fortunately, again, this is the only eye, and most of these patients have, unfortunately, we don't have choice where to go ahead. So managed to put this tug which was showing pull on the retina still. My fovea was stretched, so what I did is just tuck, okay, just create a cleavage plane here. And I know I can't peel here, I can't peel here, can't pull it. Just use the scissors to snap through in between. And what happened over a period of time, just leave that membrane, it retract on either side, and this is a limited surgery for this eye, because no way I could just pull this scar because it's a full thickness scar. So basically coming back, it's a serious complication. Incidence is somewhere between 5 to 8%, can present in early or late postoperative period. I'm talking about regmatinous detachments. There's a very high incidence of PVR in these eyes, and if once they are RD, high incidence of iris or angle neovascularization as well, and these eyes can go in neovascular. Now you need to differentiate whether it's particularly when they come in a early postoperative period, whether it's a residual SRF left because retina is mobile post-membrane dissection, or you are having a regmatinous component. If you have a doubt, just assure wait for a while. And this was a patient had a membrane pre-surgery photograph, macular traction. And once you relieve, this was a picture. We assure for more or less that there was no break created, and wait for a while. And then what happened is, over a period of time, this retina macular area settles down. Patient is doing well. But particularly when they come late onset, usually it is due to pre-retinal proliferation and leading to either tractional or combined detachment. Can also have retinoschisis, and another important component here, and sometimes secondary macular hole as well. So basically it happens due to fibrous reproliferation, contraction of pre-proliferative membrane, and we need to differentiate them from settling TRD, particularly rather than tractional detachment. I would say sometimes they can have tractional schisis, and need to differentiate because those retinas may not settle totally, but it will not worsen further. So what you need to look for is further drop in vision, worsening of the traction documented, increase in the subretinal fluid with a foveomacular detachment, and if probably quite some time it's difficult for you to differentiate breaks in these eyes. So this is one eye has a macular proliferation, reproliferation, retina was not settling down, but what you need here is you remove this membrane and this eventually will settle down. So early postoperative I already discussed about. When coming to basically the cause for tractional detachment, combined tractional regmatinous here is because there is a tangential contraction with when you have residual fibrovascular stumps. Adjacent ILM also contracts over it, and then you have reproliferation, and this can cause stretch the already ischemic retina, leading to either new break formation or opening the previously sealed breaks, and that eventually lead to change the configuration to combine RD. And this is one of the patient having a localized detachment because surrounding that laser was there, this tiny break and localized area, so needed resurgery. So risk factors, what we have here is pre-existing severe florid proliferation or flat proliferation where you need extensive dissection obviously, and there is a high risk of complication during surgery. When you need a prolonged surgical time, absence of PVD, and if you are associated iatrogenic break, excessive intraoperative. Again, all these parameters indicate that you have a more manipulation because these are pre-existing bad cases, and more manipulation induces more inflammation as well. So the cleaner job you do during primary surgery, the more clean dissection, the chances of you are reducing the risk of recurrent detachments in these eyes. So sometime during evaluation, you may not able to identify breaks, and what you need to do is sometimes good high magnification slit lamp biomicroscopy or scan through OCT multiple images. You will be able to pick up the break and will be differentiate whether dealing with tractional or regmatis RD. So principle of surgery are same more or less. I am not going to detail. Only thing is these eyes more likely to need buccal, but need retinotomy, or sometimes you clean dissection, and if possible before doing retinotomy, segmental or encircling band, you try to put in support peripheral retina, so you may be able to avoid retinotomy. That's the only difference. Otherwise, surgical principle is same once you have a regmatinous component. So to conclude, RD in post-vitrectomy PDR eyes is not uncommon. It's important to differentiate between residual retinal elevation and progressive detachment. Revitrectomy with complete relief of traction is the key for successful reattachment. These eyes generally need extensive membranal dissection and biomanual surgery. Anatomical outcome probably may not be good because you saw these case reports I have shown you, but final visual outcome definitely depends on disc and macular status. I acknowledge my fellows who helped me getting this presentation and collecting images. Thank you so much, and also take this opportunity to invite all of you to our next Retina Summit, 7th Retina Summit, which the theme is retinal trauma. which is in July. Thank you so much. Thanks, Paritosh, once again.
Thank you, Pramod, for a wonderful presentation on a very difficult topic.
Thank you.
I request Dr. Anand Pangarkar to please present the memento to Dr. Pramod. Our next speaker is Dr. Manoj Saswade. He is going to deliver a keynote address on the importance of wide field photography in retina practice. Dr. Saswade is a prolific operator. I call him the king of vitreoretinal surgery of Marathwada. And to his credit, his is perhaps the best equipped private vitreoretinal clinic in Maharashtra. And
Good morning,
one
everyone.
of the most in
First
India,
of all,
perhaps.
I thank Paritosh sir and APO, AIOS Scientific Committee for giving me the opportunity to speak in front of you, in front of my teachers who have taught me the ABCD of the retina. I will be speaking on the importance of wide field photography in retina practice. We know that I don't have any financial disclosures. You know that the wide field photography is more than 150 degrees called as wide field photography. Before that, 150 degree is the commonest one, or lesser than this is which we see with the direct ophthalmoscope or a binocular indirect ophthalmoscope. Why it is not moving? Okay. We know that the utility is manifold, but I have seen in my last 8 years that it endorses your clinical diagnosis. It is not a substitute or replacement to your clinical acumen or your clinical assessment. It also helps in assessment in the treatment, as well as the planning of the treatment, as well as response to the treatment is very important. Nowadays we are doing the lasers, injections repeatedly. That's why it is very important. Teaching and research purposes, it is helpful. It's moreover, it is a self-assessment. Whatever we have learned in the Kanski's pictures, we again see it, revise it every day, and it gives you the learning out of these things. It's again, it is importance is clinical as well as legal documentations, and moreover, in a patient's education and counseling is very important nowadays. You know that these are the end stage diagnoses. So before showing to the patient, you should show them the picture. These are the cases, rare cases. This was a central retinal artery occlusion case. We operated it. It went to 6-9, but we also come to know that in such cases, results do occur, and that documentation is very important. In cases of the vascular retinopathies, we know that these are recurring treatment requiring cases. So in these cases, at least first time you should tell to the patient, show to the patient and relatives that you are suffering from this disorder and you require repeated treatment because of this one. And these are the cases where you know that the ultra-wide field photography only can give you such a multiple venous loops. Otherwise, this was not seen in your fellowship also. So you know the aggressive management in such cases. Those cases which are the PDR cases, pre-treatment and post-treatment photographs will convince the patient. It's told that one picture is worth thousands of words. Same thing in a teaching, like in a fellowship program, we teach that what is the right laser, what is wrong laser, or treatments are being done wrong. This can be shown to the students. And advanced diabetic eye diseases, you should know that what is the starting point, how much dissection will be required in those cases. Because of this one also, we know that you are wrongly given the intravitreal injections, anti-VEGF and crunch phenomenon has been occurred. Before that, you should have a documentation. And these cases where the pediatric cases where flying baby photography is possible, where the precious babies nowadays needs to know, the parents and pediatrician need to know that what is the starting point, what is the stage of the disease, and how it is going to respond to the treatment. When you have treated these cases, you can show that these are the cases where good results have been occurred. Still, we know that the ROP is preventable. Still, such types of cases do come. So in pediatric conferences, you can show that please do refer the patients earlier. In cases of the FUAR, you know that this is a lifetime disease, keep on coming and going, so documentation is important. In cases of the Scourge disease, we know that the Scourge, but the wide spectrum of the Scourge disease is documented, and we know that this disease can manifest differently. These are the spot diagnosis cases like PHPV. We have documented the hyaloid artery. These cases like albinism, multiple variations of modulated nerve fibers, colobomas of various types of colobomas, morning glory disc anomalies. This is a congenital retinoschisis. Then various types of RPs, Betti's crystalline dystrophy. This one Stargardt's with SRNVM. Then choroideremia cases. And this is hemorrhagic as well as exudative type of PCV. We know that all these are the retina fellows who have done the fellowship. They know that this is known to us. What is great in doing this, these are the spot diagnosis cases. What is great in doing the ultra-wide field photography and spending so much of the money on that. But you know it. But nowadays, everyone wants to know. Patient wants to know. Relatives want to know what is happening into their genes and what is the trait in their families. Moreover, the referral doctors also want to know. In a VG practice, you won't give feedback to the referral doctors. If the patient goes with the photograph, they know that this was the diagnosis. And nowadays, moreover, you are also, one genius is hidden in your mind. You also want to know what is happening, whether what was the starting point and whether he has responded. Because nowadays, seeing is believing. As a retina practitioner, you are also supposed to do the evidence-based practice. Then these are the trauma cases where the evidence is very important because of medical legal things. This was a blunt trauma, shuttlecock injury to an engineer student. Mother was an ophthalmologist. You can see the extensive commercial retina. We know that because of this we could convince them very well. The patient returned back to 6/6. This was a pressure cooker injury, and photography, you can see that ultraviolet photography gives you the correct diagnosis and the follow-up. In cases of dialysis, you can see that dialysis also picked up on the ultraviolet field photography. And foreign body in other eye, you can see that the vision is 6/6, but the foreign body is lying inferiorly. You can document it before doing the surgeries. In cases of the domestic trauma, this picture ultimately saved the patient, family from the divorce. And these are the ultraviolet pictures which gives you the complete picture of how much is the severity of the disease. Upper is a pachychoroid neovasculopathy with chronic CSR, while the inferior is a choroidal hemangioma with CSR. Then other cases where the retinoblastoma was treated, and this calcium, which I had never seen my retinocytoma in practice, but we took the photograph sent for the opinion and then come to know that this was a retinocytoma. This wide field photography gives you the complete view of the melanoma also, tumor. Otherwise, it is not possible by any other means to see a complete picture of such melanomas. There are various types of angiomas which can be documented and told to the patients. Most of all, in cases of the uveitis cases, pre-treatment and post-treatment, it is very important. You cannot document each and every lesion, and how many are the active lesions and what are the healing lesions can be documented only on the fundus wide field photography. Then there are several types of vasculitis cases which keeps on coming. If you are taken a good photographs, you investigate properly, and it is a brainstorming investigations. In cases of last case, you can see that the central toxoplasma, but you have never seen such types of extensive vasculitis associated with toxoplasma. Then in COVID-19, this modality helped us a lot because it is a non-touch technology. In cases of the thromboembolic phenomena which occurred that time, we could take the photographs and document it, as well as the endogenous endophthalmitis associated with mucormycosis, also we could take the photographs. Then in cases of the flashes, floaters and peripheral retinal lesion, it is said that it is not possible to take the end-to-end photographs, but here you can see that the lattice has been picked, and beyond the anterior edges of the lattice also it is seen properly. How much more is required to see as an retina person? It is seen completely. Here also you can see the horseshoe tear was treated properly. It was extreme periphery. The lattice with subretinal fluid, that is subclinical RT, was picked up, and you can convince the patient very much. Those cases where you have done already 360-degree, whether you are senior or junior, subsequently your examination is casual because you yourself have been treated. But this case has come with the flashes and floaters with vitreous hemorrhage and had developed the horseshoe tear posterior to the lattices. Then there are cases like this one, the horseshoe tear near to the ora. Whole picture is seen on the fundus photograph ultraviolet. But again the request is that it is not a substitute to indirect ophthalmoscopy with scleral indentation. That should be practiced in a retina practice. There is no substitute to that, but it helps. which we used to spend hours together in drawing during our fellowship. But this photography will minimize your time and give you a little bit better idea on ultraviolet fields photography. Here you can see that 7 hirsute years, so it was difficult for drawing itself. Then these cases where the patient do not listen to your advice. This hirsute year was there earlier, advised the barrage laser, not listen. Develop came with after 15 days with the fullness RD, and he'll end up with the surgery. Then there are certain cases where seeing is believing again. Patients want to know what is the diagnosis. Referral doctor wants to know, then one documentation is important. In such cases, particularly if you want to know in a retina practice, there is always a shortage of dopamine and serotonin. If you want to see the first post-op picture, whether retina is attached or not, through the siliconal field or gas field also you can take the photographs. Then these are the PVR cases. Here, this was a doctor-patient bilateral retinal detachment. It was very difficult to convince him unless and until you have a ultraviolet field photography. Then the choroidal mounts, you can see the huge choroidals with RD. We have discussed this one once in a while. You have to show this patient. Then the rapidly progressing PVR cases, posterior closed funnel. Then in such cases, starting point where one should know. We are discussing on the PVR throughout the day today. And if you know the starting point, obviously you know that what is going to happen, why the recurrences is there. In GRT cases also you want to show to the patient what is the gravity of the disease, and this was a documentation. We have operated this case, retina was attached, but because of epiretinal membrane, macular hole developed, and we again went up and did the surgery, and now the patient is having 6/12 vision. Then there are certain cases in a teaching institute. Nowadays it was said that the buccal is no more done. Why? Because no one is teaching properly. That is also a part on the teachers. We can show the various types of complications of the buccal. This is needle injury with subretinal hemorrhage. There is a vitreous incarceration, higher buccal effect. Then the students can improve their practice. Next slide. Is it stop from there? Yes. This is an old RD with PVR. We were discussing whether to go for vitrectomy or that. We did the buccal in this case and it worked. Then there are several cases like anterior segment surgeons refer to you, and this is, you cannot keep on explaining them several times. If you show the one picture, it solves many problems from the patient as well as the referral doctors. There are certain cases in your practice. If there would not have been ultraviolet field photography in my practice, I could not have been diagnosed, because everything you won't learn in one lifetime. This was a case of proliferative diabetic retinopathy in the 3 months he came with the venous loops and the PVR changes, and it was a progressive, so you can give this. This is one of the case where post-pyrexial vasculitis cases we used to give the Ozurdex, and because of ultraviolet field photography, it gave me the hint that the patient had developed the CME retinitis induced because of the Ozurdex. These are the cases like Ozur, which otherwise was not possible. The photo gives me the hint. Then these are the cases of Akujis disease with Meso-Nakamura phenomenon, which has been picked. These are the certain good moments. This is one of the things with the bilateral choroidal detachment. We search this along, and then we come to know that he is taking the antipsychotic drugs, that is olanzapine, for 15 years. When we stop it, the choroidals went off. There are certain cases where you are stuck in diagnosis. Take the wide field photograph and take the opinions from your seniors. These are the cases. And this, it can be taken in a opaque media also. So there are certain limitations and myths about the ultraviolet field photography. It's ORA2 is not possible, it's a myth. We have seen that we could take it. ILS is not problem. Cost of the equipment is always a problem, but it is a mindset. If you know the value of this equipment in your practice, obviously you will forget about the cost. And it is again needs one technician, not necessary. It is more simpler than the autorep. And so the take-home message from this talk is that I have done some changes in my practice. That is, I have made a thumb rule, whether a patient is affordable or not affordable. Take pre-treatment and post-treatment, whether it is a medical treatment or surgical treatment, take one photograph. It keeps on upgrading yourself. So many pictures you are keeping every day and upgrading yourself. What benefits you get? That is, you are minimizing your own mistakes, as well as your time across the table to convince the patient is also reduced. And in my area, I have seen that it has given me the confidence and boost my self-esteem in that area. So because of it, it has helped me in documentation, follow-ups, teaching, research studies, as well as the presentation, publications, as well as legal support it has given. It's more beneficial for those who are the PG students or recently started practice. It is very important because the people who don't draw, they don't keep any legal record also. They don't keep the medical records where the drawing is not there. It is very important for them, and it's now way to go for the ultrawide field photography, because in other countries the optometrists are taking. In India also many anterior segment surgeons are doing the ultrawide field photography. Why not the retina people? That's why it is important. And retina person, if keeps on doing the only drawings, then where is the time? I think there is no next session.
I see.
Oh, okay. Yeah. So if the retina surgeons are several things to do apart from doing the drawings and seeing the fundus, so he can spare more time in doing the management skills also. So thank you very much. Set your mobile camera to ultrawide field. It's beautiful. Thank you very much.
Thank you very much, Manoj. Sorry for needling you so many times towards the end, but it was a wonderful presentation. Thank you very much
for
it.
opportunity. Thank you for giving me the.
Thank you. I'd like to thank the audience who's been there till the end for a PVR course. Wonderful audience. And before you leave, just a couple of points. We spoke about all the complex cellular and molecular pathways involved in PVR. While we don't have anything concrete except probably methotrexate, what Dr. Naresh Babu talked about, that's something moving in a concrete direction. But simple things like quitting smoking, which we discussed, and in addition, eating more dark grapes, which contains resveratrol, which helps to prevent that EMT, and vitamin B3, that is niacin, as well as our common component of our foods, haldi, curcumin. All these things would help to reduce the intensity of PVR and perhaps even prevent PVR if rest of the steps are done correctly. I thank all of you once again. I thank the speakers for their wonderful presentations, and thanks to APAO and AIOS for the opportunity. Thank you very much, all of you. I request